So our first speaker is Dr. Matthew Hollings, who is an exercise physiologist researcher who leads a research program centered around improving the quality and individualization of exercise and physical activity post-cardiac discharge, which covers a broad range of study methodologies and diverse populations, including older adults, women, and the culturally diverse. Dr. Hollings has a particular interest in the translation and implementation of evidence into clinical practice and oversees a number of new projects to develop clinician understanding and capacity to prescribe and deliver high quality resistance training in practice. He also holds a number of cardiovascular leadership positions within local, state, and national organizations. Yeah, thank you.
Thank you for the invite, CVRN and the Rising Stars Committee, and Victor Cheng for hosting today. So I'm mindful that my 10 minutes will go very quick, so please feel free to ask me some questions after if I scoot through a few things. I don't need to tell this audience the burden of heart disease, so I'm not going to. But one stat that I will draw your minds to is that every year we have around 60,000 Australians that have an acute coronary syndrome event. And the good thing is that around 50,000 of them survive due to modern medicine and the way that's growing. But what that does mean is that we have 50,000 people a year surviving and who need to manage their heart disease coming out of that. We know that the gold standard for that is secondary prevention, where we aim to reduce risk factors and prevent the onset of a secondary or third or tertiary event. And we know that exercise is a cornerstone for one of these as well. And exercise-based cardiac rehab, which is one of the most internationally recommended methods of secondary prevention, has a good body of evidence to support it and its benefits. So any patient with CVD is eligible for cardiac rehab, and it's got probably 60 years of data to show that it can reduce all-cause and cardiac-specific mortality by up to 40% within 2 or 3 years. But we do know that a higher dose is better outcomes. So something is better than nothing, and more is better than something. I heard that saying once, and I think that's a fantastic way to summarize it. So what we do know about better outcomes is we also know that better outcomes that we get in cardiac rehab will also lead to better prognosis in many different ways, including quality of life for those patients living with the disease as well. Well, I said exercise is the cornerstone as one of that, and it doesn't surprise anyone that exercise is good for you in people with existing cardiovascular disease. We know it's even better for you than just in the general population, and that we know the interaction is generally that more is better. But what we also know is that there are different types of exercise for different types of adaptations. And that's one of the most important things, is that not all exercise is equal and not all exercise targets the same outcome. So for our CVD patients, we know that our CVD patients are more than just their heart disease. We know that they have, most of them are multimorbid and have lots of other things going on. So it's important to individualize the exercise prescription as we would individualize a drug prescription to the patient needs and what they present with. So that's sort of what I'm going to spend this, and you'll link the title of my presentation with my main focus point as I go through a little bit, because I will focus on one particular type of exercise. But what I will do first is give you a little bit of context on this space. So the current cardiac rehab guidelines, and they come from most of the large organizations across the world. The Americans have some really solid ones, and ESC out of Europe have some good ones, and then most countries have them as well. This was a really great review. It's now almost 10 years old, but this was happening at the time when I did my PhD, and I was sort of following along closely. And the sort of key take homes of what the general the message of international rehab guidelines are is that most key organizations will endorse moderate to vigorous intensity aerobic or cardio exercise, so things like walking and running, in conjunction with resistance training, which is my RT there, sorry for the acronym. We know that almost all organizations support ECG monitored stress testing to work out someone's maximal capacity so that we can accurately prescribe good exercise off that. And we also know that the guidelines, mainly in UK and Australia, are quite conservative. focus on lower intensity aerobic and very rarely prescribe any focus on the resistance training or weights training side of things in particular. And so that's an area that sort of piques my interest a little bit. My PhD I did under geriatrician, and we looked very carefully at resistance training in older adults. And so that's where I've sort of taken this story into the cardiac group. But we do know that resistance training is often overlooked and not given the same level of detail. We don't fully know why, because there's a good body of evidence that it's very useful in particular for particular outputs in individualizing the treatment for particular outcomes. One of those considerations, and I know we've heard the term pandemic a lot in the last few years, so I thought quite topical to bring this up. The pandemic, by definition, is a disease that spreads across multiple countries and places, increasing stress on health infrastructure. We know that aging, maybe not as infectious as COVID, but still certainly places a big stress on health infrastructure. And we know that it's growing, and we know that it's projected to grow. They're projecting here by 2070 that more than 1 in 5 Australians will be over 65. What we also know about CVD is that our largest affected group are also older adults as well. So there's quite a story here. We're gonna have a very large proportion of adults over 65, and there's a good chance most of them are gonna have CVD as well. So this is a unique group who can certainly benefit and who have certain age-associated conditions we need to be concerned about. So one of those is sarcopenia. So for anyone who hasn't heard of sarcopenia before, it's defined as the progressive loss of muscle strength, mass, and function. And so that impacts the ability for someone to live by themselves and remain independent through life. This is typically the tipping point before frailty. So this is the point where we can interject, where we start to see some changes, but it's not affecting multi-systems as frailty does. It's sort of just we're detecting it at the muscle and function level. And we know that people with sarcopenia have an increased risk of lots of things. What we also do know is that 1 in 3 adults over 65 with heart disease will also have sarcopenia. So we know that 1 in 3 of those people have this disease that we can interject, and we have a means to try and intercept that trajectory, that potential downhill trajectory. The interesting thing about sarcopenia and CVD, and sorry for the formatting there, is that we also don't know which one comes first. So we know that the inflammation that happens in CVD can accelerate the progression of sarcopenia and the breakdown of muscle. But we also know that if you come in with existing sarcopenia and the inflammation and the physical inactivity that goes along with that condition, it can also preclude you to having cardiovascular disease as well. So it can be a vicious cycle that, if we don't break one of those two, it will lead very quickly to a patient deteriorating in some means. And the most effective, if not the only effective treatment for sarcopenia is resistance training. And so that sort of is the case that I like to make in our cardiac subset, where we've got a group that are going to have predominantly this condition that maybe if we're going to prescribe exercise in a more targeted way, for this particular subgroup, this is a type of exercise we should really think about using. So does it work is the first question, and without giving away the answer, well, I am giving away the answer. Yes, it does work. So let me take you through the evidence. So one of the first papers of my PhD was that we did a big meta-analysis of everything that had ever been done in resistance training in people with coronary artery disease. And we found that basically in those with general CAD, it didn't matter whether you had resistance training in isolation or in combination with aerobic training. We saw that outcomes across the board were better for pretty much everything. The outcomes we expect as well. So when we compare aerobic or cardio training against weights training, we wouldn't expect that resistance training would give a better cardiovascular response. But we actually saw no difference in a CAD group. So it's sort of one of these things that if we have to choose one, if we're limited on time and resources, maybe this is enough to actually tick as many boxes as we can. And we also see a very similar pattern in heart failure as well. So all those exercise-based parameters increase in with the addition of weights training. But the exercise parameters are only one part of the picture. There's a whole range of other things that resistance training can improve as well. Things that are talking about the whole patient story, like we spoke about before. One of the things that I can sort of push you towards, if we think about our older adult group, is we think about things like bone mineral density, resistance training, even though I'm not sure why there's a question mark there, is a very well-established means of improving bone mineral density in those in osteoporosis, which is another age-associated thing, in addition to those things like frailty, sarcopenia as well. So, and mental health, which is obviously another big concern in our cardiovascular cohort. So we do know it works. There's a good amount of evidence that it works. I've just basically cited some really nice figures from some comprehensive reviews here rather than give you all the boring evidence. But we also know that, as I've sort of said, maybe resistance training here is our way to interject on that CVD sarcopenia cycle and try and break that cycle and give our patients a better quality of life and better prognosis out the back of their heart event. One of the biggest concerns in this space has always been safety, though. Often many of the physicians that I speak to are concerned with the resistance training because it often feels like you're straining yourself. It feels like you're going to have a heart attack if you lift something heavy. It does feel like it, but there's no evidence to say that it increases cardiac load at all, compared to aerobic exercise at least. I know that as part of that big review, we looked at adverse events. We did find 6 studies reported on 63 non-fatal CV complications, and only one of those was during weights training. Everything else was during aerobic training. So this idea that resistance training can affect the heart certainly hasn't been documented in RCTs. But we do know that the majority of complaints we get from weights training are musculoskeletal in nature because of the nature of the load. And that can be attenuated by, having trained professionals or individualizing, if people come in with pre-existing conditions like osteoarthritis, we expect that they're going to be exacerbated, but we can change the exercise type so we don't exacerbate as much. So things like that is not unexpected that we see more musculoskeletal, but in terms of CV, not as much. When we compare it directly to aerobic training, we know that it is safe. So my scales are slightly thrown out, but you probably still get the message there. What you've lost is the legend. So systolic is in the blue bar, diastolic is in the orange bar, and then heart rate is in the gray bar. And so what we're comparing here is we've got 3 different weights training modalities here versus an aerobic training cycling. All of these were a submax style of exercise, so something where they're exercising at around 70 or 80% of maximum. And we can see that the mean change in systolic and heart rate, which go together to make the double product, which is a marker of cardiac load or cardiac oxygen demand, should I say, is much higher in aerobic setting. So the load on the heart is going to be a lot higher for a steady state aerobic style than the transient increases that go along with the weights training. So again, the case of that sort of case that we're concerned about blood pressure responses, which is a very common one that I get from physicians. There doesn't seem to be any good solid evidence. Obviously, I'm only showing you a handful of studies here. What you're looking at here is wall motion abnormalities. So we're looking at changes in contractility or contractility abnormalities. So at rest, we've got a group that have had STEMIs, so we expect that they're going to have a good amount of abnormalities. And when we throw them into different maximal exercise tests, the GXT over there is a general stress test, so cardiac stress test on a treadmill where you go to maximum, and then the other 2 are 2 different types of leg or arm weights training where you go to maximum. And again, no difference in regional contractility changes during the exercise. So inside the heart, as well as the blood pressure, the indirect things don't appear to be negatively impacted, at least at all. When we look at intensity, again, same story. Often there's some hesitation about higher intensities, that they might be slightly more dangerous. A really good study that was done a few years ago now looked at 2 different intensities. So what we've got here is we've got the open circles there are looking at an intensity around 90% of someone's max. And this is a group of 60, I think the average age was around 62 people who had just had a cardiac event. What we saw was that the higher intensity, but less reps. So the open circle, sorry, I'm getting lost here, my bad. Open circle is 90% of maximum for 4 repetitions. The closed black circle is 60% of maximum for 15 repetitions. So basically, the take-home message of this one was that the systolic blood pressure increased more with the more repetitions, regardless of which intensity that it was at. So it seems that at least in this example, intensity doesn't seem to be a driver of systolic pressure increases, at least. It just seems to be that the actual volume, the number of repetitions. So by that, it's, should we actually be thinking about prescribing less repetitions to prevent that cardiac load going up? And that's sort of a question that potentially might drive some future research that we're doing as well. So just to sort of, and I forgot to start my timer, so please let me know how I'm going. But I'm sort of on the last few slides here anyway. But think about barriers, and this is where most of my work is heading now. One of the biggest barrier is that we have a very low uptake of cardiac rehab in the country, in Australia and across the world. So we know that only typically 1 in 3 eligible patients end up enrolling in cardiac rehab, and typically only 1 in 10 end up completing it. So it's as a gold standard intervention where we can actually intervene with really good quality stuff. We don't actually get the engagement. So it's about thinking other different ways, telehealth style things that we can engage more people and sort of get engagement in cardiac rehab a bit better. But that, I guess, from my perspective, for those who end up in that system, how can we better train the clinicians to develop good quality and sort of develop some really good resistance training practices in those? So again, another study we did is where we looked at practices across Australian cardiac rehab programs and sort of looked at basically what they were doing and how it stacked up to the guidelines. So what we know in terms of a workforce perspective is we know that in Australia, most cardiac rehabs are delivered by nursing staff. There are some physiotherapy as well. Exercise physiology specific are quite low. It makes around, I think that's around 30% of services. So they're the ones that are going to be potentially in a better position to deliver high quality. But there's also going to be a resource-based question as well. And so what we're looking at here is the majority of tests that were done. And we see that physical function tests like a 6-minute walk where no equipment is required is the most common test done across the country. But some of those more complicated tests, like the ones going to be down this end, strength training and like an aerobic fitness test, are much less frequently done, which is a resourcing based issue, potentially a staff based or potentially equipment based. So we've got a few things potentially working against us, but we did in a sub-analysis here find that those who had access to high quality exercise equipment, like treadmills, like stress testing equipment, were able to deliver a better quality exercise prescription in terms of the intensity prescribed and a balance of aerobic and resistance training. So that in itself is an interesting one. We only last year, so I co-led this statement on behalf of Cardiac Society and the Australian Cardiac Rehab Association as well. And this was the first ever Australian guidelines on exercise in cardiac rehab. And so as part of this, for the first time in this country, we had some really clear direction on what to do. What the process should be in terms of how we assess, prescribe and adjust exercise to deliver it in the most accurate way, but also having equal reliance on aerobic exercise, resistance exercise, and then physical activity, which is any non-specific exercise or movement that happens outside of the service. And so this is something that now has given us a platform to move forward and start implementing, and that's where most of my efforts are going at the moment. So I'm just going to wrap up with sort of give you a run through of some of the current projects. So I don't have too much hard data, but stay posted. I'll have some in a few years. So the first one that we're doing is that we've got a pilot grant from the Sydney Health Partners to look at developing a digital tool to improve the uptake of weights training in cardiac rehab. And that's going to leverage the guidelines that we've just written and develop an easy way for some of those non-exercise trained staff, like the nursing staff, to engage in resistance training and sort of teach them how to deliver good quality when they may or may not have equipment available to them. So that one's underway at the moment across 2 LHDs, Western and Northern Sydney. We're doing a very big systematic review and meta-analysis of the safety of resistance training in older adults, of which one of those sub-analyses will be cardiovascular group. So this at the moment, as we come to our full text, we're looking like we're going to have about 350 or 400 papers in that. So it's every RCT that's ever been done on weights training in older adults. So there's quite a bit to move through on that one. So that's going to be a really good resource to lean on from an evidence standpoint and the safety of it. Main outcome for us is serious adverse events in that, but there's going to be a lot of other things that obviously will come out of that. We have just established a national task force to improve exercise physical activity assessment and prescription across cardiovascular disease. And so this is led by a few different institutions, but I co-lead this with an exercise physiologist out of Queensland. And the idea for us is to sort of create a national network of methods that we can try and develop this. And that will probably look like having some type of education initiatives that will be having living guidelines, resources that clinicians go through, that sort of stuff, where we can just sort of work towards that implementation of the evidence. Because in our space, we've got we've got a lot of clinical trial evidence. We don't need to do any more clinical trials. We just need to get it into practice. So that's sort of where we're looking to move to at the moment. And the very last one is that I'm the only allied health member on the National Education Committee of Cardiac Society with all my cardiology friends. I'm flying the flag for exercise, but it gives me the ability to actually develop some educational modules to go directly to the cardiologists to try and get the physician support as well to sort of to move this space a little bit more or work out where those barriers are so we can try and fill those gaps. So that's sort of it in a nutshell at the moment. So watch this space in a couple of years. But just to quickly sum up, obviously in my space, as I've said, there's a need for implementation of it. We don't need to redo many more clinical trials in the space, but it seems that we do need to educate everyone in the field on how to develop and how to deliver really good quality resistance training, particularly for those who need it most. We do need to champion the individualization of exercise and treat it like a drug, because we have about 60 years of evidence to say that it is as effective as many drugs for many different outcomes. So we need to start treating it that way. And we also do need to consider, obviously, all those that will not make it to a face-to-face setting and how we can engage those patients to use exercise as a medicine in their particular setting. So that's it. Just like to finish up and thank my long mentor and supervisor team for their help on all these projects, and many other co-authors and everyone that's helped on lots of stuff. So that's me, and happy to take questions now or after.
That's all right. In the interest of time, we'll do questions after, at least maybe for Matt. So our next speaker is Dr. Kelly McLeod, and she's a lecturer and accredited exercise physiologist within the School of Health Sciences at UNSW, with over 15 years of clinical and teaching experience within the UNSW Medicine and Health Lifestyle Clinic. McLeod's interest in evaluating exercise physiology services led to commencing clinical research. McLeod's PhD site, or Exercise to Decrease Cardiometabolic Disease Risk, was awarded in July 2023, investigating exercise and lifestyle interventions for older adults' cardiometabolic health. Future clinical research looks to evaluate multidisciplinary exercise and education interventions for older adults with multi-morbidity, also engaging undergraduate students in the clinical and research intervention.
Thanks for having me today. So I suppose today I'm probably going to focus on the main project for my PhD, which we call the Diabetes Clinic. So I'll just give a bit of context for that first, and then dive into some of the results that we found. Again, we're in this room probably pretty familiar with the incidence of diabetes in Australia. I suppose adding to that 1.3 million, about almost 60% of those in Australia are aged 65 or above. And that was a group of, that older adult group was the group that we tended to focus on in my PhD. Again, just associated with the prevalence. We know that there's a range of cardiometabolic risk factors that contribute to cardiometabolic health, and older adults are more likely to have these risk factors compared to younger adults. I suppose the red box there on the side almost 87% of older adults are not meeting the physical activity guidelines, which call for 30 minutes of exercise most days of the week, 2 or 3 sessions of those ideally should be strength training. So again, I think a lot of these risk factors are pretty available in clinical practice. Unless you're an exercise physiologist, though, the fitness measures are perhaps not taken. So I love the exercise as a vital sign concept, and that could be something for future research and clinical practice implementation as well. So in terms of cardiorespiratory fitness and muscular fitness or strength, we know that these are protective factors across a range of outcomes. They can reduce the risk of type 2 diabetes. They can reduce the all-cause and CVD mortality. So again, obviously, alongside Matthew, we're pretty big advocates of exercise in this space because we know it can have a big impact on some of the biggest health conditions that are affecting our country and globally. So EPs or AEPs, accredited exercise physiologists in Australia, in 2006, we were included under Medicare to provide rebatable services. So this originally just included individual services. And in 2007, there was another item introduced, which people with type 2 diabetes were able to access an additional assessment and 8 group sessions in a calendar year. So despite these services being available now for several years, they are really underutilized. So those figures there were from 2019 to 2020. Again, those figures were sort of picked because that's the time that I was doing my PhD. Be mindful they perhaps were also affected slightly by COVID, and what services may or may not have been able to be delivered face-to-face. But really what these numbers show is that less than 1% of Australians with type 2 diabetes actually have these services, even though they're there, they're rebatable. So I was kind of intrigued as to why. We already have this system set up, people can access it, they can get free or rebatable services. Why aren't we using it? So it led to the development of our diabetes clinic trial, which was a feasibility, acceptability, and preliminary efficacy pilot trial. So what this looked like in practice, we did a pre-intervention focus group just to make sure that we were on the right track with what we thought should be included in the study. We did get ethics permission to use the existing Medicare items. So those items up there are the exercise physiologist specific ones. As a dietitian or a diabetes educator, you're also able to deliver those services. But it was just me as a PhD student delivering it all in this study. So they came through for that group service, which looked like an hour and a half of supervised exercise and education. So we did an hour of exercise. Half of that was aerobic, half of that was resistance training, and then 30 minutes of group education that was intended to be participant-led. Final assessment, final focus group, and 6-month follow-up. So our primary outcome was feasibility, with attendance set at 5 out of the 8 sessions, and that was selected because that's sort of in line with how many sessions people attended with the Medicare services following an initial assessment. So what we found, they came, which was really good, and they seemed to enjoy it as well. So with the attendance, we did have a really good participant attendance rate of 7 sessions out of the maximum 8. The largest reason for non-attendance was COVID. Again, unfortunate of the times that we were in. and also the policies that we were working with within the clinical space in the university as to how long people had to wait post-COVID to return to the trial or service. But overall, really, really good results. So I suppose showing that there's the opportunity here, people seem to like it. They really enjoyed the group aspect and that social component, which I think naively I had perhaps underestimated the importance of that. So again, in future research, I think that would be a bigger area to capture more insights objectively moving forward. I suppose the other things that we looked at were changes in the outcome measures. Now, obviously there's limitations there. This wasn't an RCT. We just had one group. Everybody did the same thing. So interpret that with these results with that in mind. But we did see significant improvements in blood pressure, some of the anthropometric measures, function, so 6-minute walk test, muscle strength. And interestingly, some of these results, particularly blood pressure, that was also clinically significant. So I suppose what we're looking for is like a 2 to 5 millimeter of mercury change in blood pressure for that to be considered clinically significant. So across the board, that was there for all blood pressure readings. What was a bit disappointing, I suppose, there wasn't any improvement in blood glucose or HbA1c. Now, again, this intervention was once a week for 8 weeks. So in the context of exercise, that's not a big volume. And also for HbA1c and all of the blood measures, we chose not to take those measures ourselves. So these were the measures that we were relying for their other health professionals to have taken and report back to us. So there was also low numbers in terms of what was being done. And I suppose, again, we chose to do that on purpose because that's typically what happens in clinical practice. The exercise physiologist is not the person that's taking somebody's bloods and assessing that pre-post intervention. We rely on the GPs, endocrinologists to have those measures taken, and we're sort of seeing where things land. Also limitation of the facility that I was in at the time, and whether it was safe for me to be able to take bloods there. So I suppose our overall conclusions, this sort of service in practice is feasible, is acceptable, and has the potential to be effective across a wide range of cardiometabolic health outcome measures and improving fitness. Again, there wasn't any change in glycemic control, but other evidence has suggested that these types of exercise interventions do have the capacity for that. A similar program run with the NDSS called Beat It. They run a 16-session twice-a-week intervention, and they've run this face-to-face and via telehealth during COVID and have similar improvements as well as improvements in glycemic control. So interesting. I wonder if it's the additional session per week, is that frequency that we're needing? If it would also be handy, obviously, to have a control group to compare to, and obviously a few other factors that could influence these things. We didn't control for medications, previous exercise, additional exercise, or dietary intervention. So again, lots of potential confounders there. So where are we heading? Taking that feedback from participants with the final focus group, they were really keen to have a dietitian on board, which I suppose makes sense. A lot of the participants had perhaps already been familiar with exercise services, and whilst they found the group setting novel and they quite enjoyed the social aspect, they were really seeking that other expert opinion from a dietitian to support them in that space. the multimorbidity aspect, like naturally, the participants that were attending had 5+ health conditions typically. So our new study, the Meta Health Clinic, is looking at a similar program for people who have type 2 diabetes and comorbid osteoarthritis. Now we know that if you have type 2 diabetes, there's at least 50% of that population that have comorbid OA. And we also have some philanthropy money with the Lifestyle Clinic that's interested in research in that OA and osteoporosis space. So nice way to collaborate. And I suppose, you know, service clients and people who are ready to do research participation that have more than one health condition and not exclude them for having more. I think one of the other things that would be really handy to see in exercise research is this comparison between statistical significance and clinical relevance, or whether a result is clinically important. Often we might see that for the weight and the waist circumference for our diabetes clinic trial, that was statistically significant changes, but it wasn't really clinically meaningful. So I think it's important to report on both there and help our clinicians be able to, and especially younger sort of students entering the workforce, that can be really helpful for them to identify and understand if an intervention is making a change or not. Also comparing different services. So since COVID, the individual Medicare services available that EPs can deliver are also available as telehealth services. This has not been the case, unfortunately, for the type 2 diabetes item. So we're not able to deliver that service via telehealth. But again, a comparison to see whether telehealth as an individual session could be helpful. So our new trial is either people are waitlist controlled, so there is a control group. They do 8 group sessions, or they're randomized into 4 telehealth sessions. And again, there's a discrepancy there in the volume of touch points, but that's to align with the Medicare items that are available. So where to from here? I think the clinical practice, I agree with Matthew's comment before, it should be individualized. There's so many different types of exercise and what an individual can perform and what they're going to be able to get the most out of. That can obviously be challenging if you're doing group interventions, but it's not a limiting factor. And it should definitely be multimodal. So there should be strength, aerobic, balance training was another thing in the feedback that our participants were interested to have more of. Having exercise and fitness tested, as well as your blood pressure and glycemic control, to help with identifying your cardiovascular risk. Understanding what some of the barriers are to EPs, GPs, whoever else, in assessing for cardiometabolic health, and providing physical activity counselling or referrals to appropriate services. So our GPs in our local area in Randwick, they're really familiar with our lifestyle clinic service. They always refer. Well, as EPs, we get like 5 out of the 5 allied health sessions, which is really unheard of. In other areas of Sydney, that would never happen. But when I asked them to prepare this type 2 diabetes referral, they didn't know what I was talking about, and they always sent me the 5 sessions. So I found that really interesting. They knew about EPs, but they didn't know about this service. And I suppose if it doesn't run in their area, why would you know that there's another Medicare item to accommodate it? So I think I've seen recently our Exercise and Sports Science Australia doing some really good education and GP outreach in Western Sydney to just upskill the EPs and other allied health in the area, as well as referrers to help with improving that process. And also accessible healthcare. How can our telehealth be best utilised for this group? Cool. That's me.
So our next speaker is Angus, and he is a PhD candidate at the School of Public Health, Faculty of Medicine and Health, at the University of Sydney. He is a registered nurse experienced in various areas of cardiac nursing and teaches anatomy and physiology to future registered nurses at the University of Notre Dame. And his PhD project on elite athlete cardiac screening focuses on understanding sex differences in elite athlete electrocardiograms, assessing and providing guidance on the use of modern electrocardiogram technology, and addressing challenges in the implementation of cardiac screening in sporting organisations. Angus is also a member of CVRN and Sports Medicine Australia.
Thanks, Ziggy, and thanks for the opportunity to present today. So athletes experience transient arrhythmias that are associated with intense exercise and are hard to capture with traditional monitoring, things like Holter monitoring. Smartphone devices that capture ECGs are a potential solution, like the Cardia 6 lead that appears on this slide. Genetic heart diseases can be associated with some transient arrhythmias, particularly in athletes. And so the aim of this study was to assess the Cardia 6 lead device in athletes, but also in a genetic heart disease population. So we had two distinct groups in this study. We had healthy elite athletes and those with genetic heart disease, which we referred to as positive controls. Each had a resting 12-lead ECG followed by a 30-second 6-lead ECG, appear like we see on the figure on the screen. And we assessed the 12-lead and 6-lead in EPS digital capillars, and we looked at rhythm and also particularly manual measurements of the ECG. And we plotted those manual measurements on Bland-Altman plots to assess agreement. So moving on to results, we had 233 healthy athletes with a median age of 17 years. There were 43.5% female, and we had 49 positive controls with a median age of 50.5. There were 41% female. About the ECGs, there was complete agreement in sinus rhythm. Moving on to the Bland-Altman plots. Won't go through them in detail given time, but to summarize, in athletes, we saw heart rate and QRS duration had quite high agreement. We found less agreement when it came to QTC and PR interval measurements, with overall QRS, QTC, and PR interval being shorter in the 6-lead device. Very similar story in the positive control group, with heart rate and QRS duration again being high in agreement, QTC and PR interval less agreement, and again shorter QRS, QTC when it came to readings in the 6-lead. So in conclusion, 6-lead had relatively high agreement with 12-lead. All 6-lead measures except heart rate were slightly shorter on average. Looking at its best use, best for rhythm and QRS duration measurements, and to expand the role of device, we would want to compare it with other portable ECG devices like the Apple Watch and various others. I'd like to thank my supervisors, Tim Driscoll, Jessica Orchard, who's here today, and Belinda Gray, and thank the rest of my state team. Thank you.
Thank you. So our next speaker is going to present virtually, and it's Rebecca, and she studied a master's in public health and is a final year PhD candidate at the University of Sydney. Her vision is to harness the benefits of digital technologies to improve adolescents' health. Throughout her PhD, she has conceptualized and led a nationwide clinical trial to test the efficacy of Health for Me, which is a novel digital intervention for adolescents aiming to improve shared risk factors for physical and mental health. She actively works alongside adolescents to inform all aspects of her research, and she has received competitive scholarships throughout her candidature and currently sits on national and international committees relating to her research.
Wonderful. I'm really sorry I can't be there today to present. Unfortunately, I'm unwell and didn't want to get anyone else sick, but I'd like to present to you some of my current PhD research. So for this presentation, I will be using the Health for Me study, which I've been leading throughout my PhD. And we know that there is a need to develop accessible interventions to reduce risk factors for cardiovascular disease through primary prevention. Therefore, the Health for Me RCT aim to recruit otherwise healthy adolescents 12 to 18 years old, and the intervention is a 6-month co-designed text message intervention, which aims to improve nutrition and physical activity behaviours. The study is a virtual clinical trial, meaning there are no physical sites for recruitment. We recruited adolescents through social media, direct emails through schools and NGOs, and through known networks. However, today's presentation will focus on the recruitment of adolescents through social media. So we had 3 data sources: the recruitment and screening logs, the social media advertisement data, which came from the back end of Meta, and the participant characteristics, which were collected during screening. These data sources were combined and analysed using descriptive statistics to understand the effectiveness and the cost of social media ads, and chi-squared tests to assess factors associated with non-participation in the study. Using the screening logs and social media data, over 12 months we received 2,369 expressions of interest to join the study, and out of those, over 91% heard about the study through social media. We'd run 17 ads through Meta, which simultaneously displays the ads on Facebook and Instagram, and reached over 400,000 unique accounts. We also reached all states and territories across Australia and all genders. And the cost for running these ads was low at $3.89 per participant enrolled. We also compared participant characteristics collected through screening of the group who were eligible but did not enroll, as seen in the yellow, with the group who did enroll in the study, as seen in the purple. And we used adjusted standardized residuals to measure the strength of the difference between the observed and expected values. What we found was that there were statistically significant differences for both gender and recruitment strategy, with fewer participants identifying as male and more identifying as other genders enrolling than expected through chance alone, and fewer participants enrolling through Instagram and more enrolling through other methods such as emails than expected through chance alone. So in conclusion, the social media was effective for recruitment and low cost. However, we really need future research to understand adolescent perspectives and build trust regarding health information on social media among adolescents. And I acknowledge that with the media this week, this might be quite challenging. Thank you so much.